Hello, my name is Jeff Howe from George Fox University, and the main focus of this talk is going to be trying to get the implementation of PROMIS at the point of care to be relevant to providers, and in particular physiotherapy providers. So we're going to take 3 deep dives contrasting the value of the PROMIS physical function scale with performance measures, and then contrasting thinking about the value of adding mental and social health outcomes, and then finally moving this toward a person-centered care approach. So one of the studies we started with in PROMIS had to do with comparing physical performance tests that we see in this table here on the left. Down bottom left, we see the modified physical performance test and the R values with the PROMIS physical function scale. And overall, the correlations between these performance tests and the PROMIS measures were positive, supporting the validity of this self-report. But one thing we want to do is take a deeper dive with the correlation of 0.64 and what that means for clinicians. So if we look here on the y-axis, we see gait velocity, then we see on the x-axis the PROMIS physical function scores. And if we draw a line at 48, we can see these two people that have essentially 100% difference in their physical performance tests with the exact same self-report. So this kind of thing for a physician or for a provider can cause a lot of questioning of which measure to use and which is better, or how do you rectify that. And this is not just in this particular study, but it's reported also in other self-report measures, not PROMIS, this being the Parkinson's disease, where there's a disconnect between self-report and ADLs. And here in arthroplasty, we see the same thing, and then this is another arthroplasty study. So we're really interested in trying to help understand why the performance measures might be different than the physical performance test, PROMIS physical function measure, which is perceptions and belief. So we use the 1-minute sit to stand test in this mixed method study. These are 10 patients with knee-OA. We use 2 perception scales. One was the rating of perceived exertion, which kind of rates the perceptions of difficulty of that particular task. And then we use the PROMIS physical function to capture beliefs and perceptions about their overall ability. And then we also looked at qualitative analysis using semi-structured interviews and thematic analysis. So the rating of perceived exertion for the 1-minute sit to stand suggested that the task was hard to very, very hard. So very it was the full range of this kind of green and red space on the rating of perceived exertion scale. And then in terms of their perceptions and beliefs of their physical function identified by the PROMIS, they were on average and comparable to the U.S. average, but the range was that they were 2 standard deviations below to a standard deviations above average. So quite a range of perceptions. So now when we tested them, what we kind of noticed in these gender and age matched percentiles is essentially they range from 2.5%, so very, very low, to 75%, very, very high for this kind of elderly cohort. And what we also noticed is that same discrepancy I showed you before was present in this study, where we had a person who was at 2.5 percentile in the sit to stand score that really saw themselves as a standard deviation above average, and then a person who was in the 75th percentile on their performance-based sit to stand test, and they really saw themselves as average. So real disconnects in either direction related to perceptions and beliefs about their ability and then their actual performance. So when we looked at the thematic analysis of the test itself, most of us see this test as testing physical ability and restricted by pain and muscle performance, but the patients or participants identified this kind of strategy development to kind of score higher or gaming the tests, internal motivation in terms of competitiveness, and then external motivation, kind of motivated by the influenced by the way the researchers were thinking about them and their performance, or the therapist or clinician thinking about them and their performance. And then finally, emotional processes like performance anxiety, confidence, and then many of them experienced joy during the test as they were succeeding and completing the test. So the bottom line is there's a lot of cognitive processes that potentially could influence performance. And so when we look at these two things, we think about performance as a clinician, we think about performance and perceptions. There's an argument that both may be important. On the one hand, how much can I actually do? And on the second hand is what are my beliefs and perceptions of my abilities? And you might think about it, if I have high perceptions of my abilities, but I'm actually a low performer, well, then I may not take advantage of treatments that could actually help me. And in the reverse, if I have low perceptions, but I'm a high performance ability, high capacity, I might choose treatments like surgery that I think are going to help me that might not help me at all. So calibrating performance with perceptions and making sure that those are aligned could have strong benefits for patients that are considering different treatments. The second deep dive has to do with exploring the benefit of including mental, social health outcomes with physical outcomes. So we all are in agreement that pain interference and physical function are good measures to use in physiotherapy and different orthopedic problems. But the second question is what about the social and mental health scales? And we look at something like the patient acceptable symptom state. We have good studies that support that adding social and mental health scales help us predict whether a person feels like their outcome was acceptable better than just using the physical health scales alone. But what I want to talk about right now is a different study that we haven't quite published yet that tried to use the PROMIS physical, social, and mental health scales to predict a scale that predicts the risk of persistent symptoms in 2 outpatient orthopedic clinics. And what we found was that essentially physical health domain measures, mental health domain measures, and a combination of all measures predicted successfully the Keel MSK tool, explaining 40 to 50% of the variance in that outcome tool. So suggesting that, again, that more measures are better than one for predicting persistent symptoms. So all encouraging clinicians basically to use these measures and start seeing the patient, not just as a diagnosis, but more as a more complicated person with many factors affecting their pain experience. So but the deep dive here is that we wanted to look at if we were to show these scales to the therapists, how helpful did they perceive them to be at the point of care? So we came up with this PROMIS report card you see here, where red is like worse relative to the U.S. average and green is better than the U.S. average on 7 different scales, including physical function, self-efficacy of symptom management, pain interference, fatigue, depression, anxiety, and role satisfaction. And then their numeric scores are kind of written here by hand. And so during an encounter, we would show them the scale, and then immediately after we showed it to them, they would rank whether this information helped them evaluate their patient on a 0 to 10 scale. So we can see the patient mix here on the left, and then we were able to document this in 58 encounters, and we can kind of see the helpfulness scales here on the right. And in 64% of those 58 encounters were ranked as higher than 7 on the 0 to 10 scale. And when we inquired to the therapist why they ranked them higher, essentially one of those items they had expected to be not an issue, but the PROMIS measures identified them as an issue that they hadn't picked up by their normal subjective and interactions with the patients. So then the last deep dive is really getting at why a person-centered approach is potentially better, and how PROMIS may help us leverage that into that approach with efficiency. And so in this particular study, it's just getting underway. There's some of the first 2 participants are these 2 assisted living residents, and you can kind of see this person on the left is really kind of age-related shoulder and musculoskeletal aches and pains. And then on the right, we have a person who's got general mobility problems and then a mental health issue. But we really have no kind of picture of when we walk in what to expect. And so the PROMIS scales kind of immediately help us think about, how to prepare for each patient before we get into the room. So we can kind of see that illustrated here. So on the left, we have our patient with this kind of age-related aches and pains, and we can kind of see that all of his physical health, mental health, and social role scales are within a standard deviation of 50 or the U.S. average, except for physical function. So we might anticipate that this is more of a straightforward musculoskeletal problem. And on the right-hand side, we can kind of see that, we knew that this person had mental health issues before walking in, but now when we look at the PROMIS profile on the physical, mental, and social role scales, we can kind of see, well, this person is beyond a standard deviation in severity of all of these symptoms and function. So what that allows us, though, to do is to start to use kind of a different approach to patient care. And so what this study's about is comparing the provider-centered, structured, and scripted evaluation to a person-centered, structured, and scripted evaluation within 48 hours on the same person. So the evaluations are performed by different people that understand the scripted and structured assignment, but they're evaluating the same person. So this project's being led by Dr. Philbrook and is a collaboration between George Fox University, University of Utah, and Touro University. And this is Dr. Philbrook on the left, which is conducting one of the qualitative interviews following the two structured evaluations. And you can kind of see the difference to kind of illustrate the difference between a provider-centered and a person-centered approach. So now, if we're going to move over to your session with Tyler, I'm going to kind of do similar types of questions. How helpful do you feel that session was?
Very.
Very helpful.
And I want to explain the difference.
Yeah.
Lynette comes across as very professional, knows what she's doing, has kind of in her mind sort of what she would recommend and all of that. Tyler's just the opposite.
How so?
He's very bubbly.
Okay.
Very much interested what I am thinking, not what his expectations were. And so he comes across not as professional, he comes across as very personal.
Okay.
And he said more than once, I'm not here to be particularly a professional. I want to be here to help you do what you can do. So you are going to lead me. I'm not going to lead you.
Okay. So kind of the patient leading.
Yes.
Okay.
And it was very relaxing, very quiet, but he's very boom, boom. When I first met him, I thought, oops, I don't know that I'm going to get very far with him because he was so bubbly.
Yeah.
But his approach was very, very personal.
Good.
Like he didn't have any answers. He said, you are the one that's going to give me the answers.
Yeah.
I'll give you choices.
Yeah.
But you're going to give me the answer.
I couldn't have said it better. The difference really being highlighted is provider-centered is good, and he acknowledged that, but then you saw what he said about a person-centered approach. So in terms of the different barriers to implementation of PROMIS, what this presentation tries to kind of motivate is the idea that at each level, the adoption of PROMIS has to do with its utility and clinical decision making, and has to do with interpretation of the scores, kind of alerting us to measures or symptoms and function that we wouldn't have normally caught in our subjective and objective evaluations, and finally, it helps us kind of see the need for a person-centered approach in kind of a variety of patient cases. Thank you very much.